Thank you, Ariel. And it's good to meet everyone this morning. Welcome to the MCI commercialization webinar. As Mia said, I'm Frank McGillin. And today I want to talk about partnering with academic medical centers. I want to share 5 lessons that I learned over the past 5 years working with Cleveland Clinic. I spent my career building healthcare and health tech companies. Companies like Johnson and Johnson were involved in a number of RX to OTC switches. Philips worked on everything from globalizing the Sonicare oral healthcare brand to capital medical equipment, did 2 startups in the Boston area. And for the past 5 years, I was leading a joint venture between Cleveland Clinic and Amwell, a digital health, telehealth technology company. And so I want to share a little bit of the experience I gained working in the joint venture. I think everyone here knows Cleveland Clinic, a 100-year-old academic medical center, one of the most incredible institutions if you're talking about cardiac care, and just a really high-quality academic medical center. The other partner was Amwell, high-growth technology company founded by 2 Israeli entrepreneur physicians. So as you can imagine, very different cultures between the 2 organizations. Because of the organizational structure, I had sort of the inside view of how Cleveland Clinic worked and made decisions, and that's what I'm basing the presentation on today. So in terms of our learning objectives, it's really a framework to evaluate health system partnerships. And there's a saying, different horses for different courses. AMCs can be a great partner, depending on what your goal is. In other cases, maybe not as appropriate. So I want to talk a little bit about how to make those decisions. Want to explore what motivates AMCs to partner, to make decisions, how to navigate and build relationships, who is that right internal champion for your project or your product, understanding potential upside and common pitfalls, as well as the importance of alignment. Also want to spend a little bit of time on what are some of the hidden costs of getting it wrong? Because you get it right, the endorsement that you get from a Cleveland Clinic, a Mayo, a Johns Hopkins is invaluable. But if you get it wrong, you could burn 12 to 24 months in the sales cycle. And I put sales in quotes because that could be trying to get a publication or a research partnership, or it could be commercial partnership. The reality is, though, it's a longer sales cycle. And if you're a startup, time is money. Time, you're burning money and could be doing other things. There are significant integration lifts, cybersecurity reviews, EMR integration, workflow mapping. It all adds up. So you want to be real careful. That leads to potential diversion of your teams and your focus as the leader. And there's the opportunity cost from all that. And the challenge is, and the problem isn't rejection. That's not the worst thing. The worst thing is that you burn a lot of calories over a long period of time and end up empty-handed. So I want to hopefully talk about some things that maybe could help prevent that from happening. So before we get into it, I did want to do a quick poll. How many people are currently pursuing AMC partnerships today? And if you just want to respond in chat. Let's see, Rachel, okay, thanks for being the first to chime in. Well, we have at least one. And Rachel, I'm just curious, what direction is the partnership you're exploring? Is it around research or a commercialization opportunity?
Well, we have more than one, and I would say in the cases where we have a research partnership, the idea, of course, is to do a real-world quality improvement pilot to drive commercial utilization in the future. So we're not doing research for the purpose of research. Where we do research, it's to drive commercialization because we are already an FDA-authorized device.
Excellent, thank you. And David, I see you said we are as well. Maybe, David, can you share a little bit about the direction you're going with your partnership opportunity?
Yes, so we recently also signed an agreement with the Jefferson Health System, and that's a big center that is also partly academic. And we are also moving on with Hartford Health, which is a Yukon partner as well. And Mayo Clinic is also one of our partners that, is also commercial now. So several, one, I have to say Cleveland has been the hardest one to work with uh, by far, right? So I really value your, insights and sharing your experiences.
Yeah. Hopefully I can be helpful, and I can tell you they are a challenging organization. Well, thanks for sharing it. And I also say, part of the best learning with these webinars comes from interaction with the team. So if there are additional points anyone wants to add along the way or during the discussion at the end, please chime in. So AMCs think differently than normal, I'll call normal businesses. Mission and reputation really are paramount, and it really drives a risk aversion, but they also have to manage to a bottom line. And being a nonprofit doesn't mean you don't worry about margin, doesn't mean don't worry about procedure revenues and all those sorts of things. But there are other things that highly motivate the academic medical centers, things like rankings and US News and the various hospital rankings globally, research leadership, the institutes, departments, depending on what they call them, their own little kingdoms, whether that's cardiovascular or cardiothoracic surgery versus neuro versus others. But there are different uh, groups within the hospital that all have different views, different goals, different objectives, and it's important to think about that. Brand reputation is critical, and net promoter, that patient experience. Generally, there's some community health part of the mission, and they are really motivated by these complex, high value procedures. They have, the top physicians, the top surgeons in the world, and they really want to be at the cutting edge of those procedures. They care deeply about, they care deeply about helping patients and advancing care to that next level. So we'll talk a little bit more about what this looks like as you're thinking about potential partnerships. My experience, I boiled down to 5 drivers of a successful partnership. We'll talk a little bit about all of these today, but it starts with alignment. Are you going in the same direction? Relationships, how to build high value, productive relationships, how to talk about value creation, the getting to that right physician champion that really can make or break a project. And finally, the importance of integration, particularly if you're thinking about scaling a program long term. So let's start with alignment. Academic medical centers, they're complex organization. They've got multiple stakeholders, physicians, department heads, administrators, marketing. Generally, they have at Cleveland Clinic, it was called market and network services. But basically, those are the folks that were selling and the deals with the health plans, with the large employers to bring patients into the facility. IT, finance. We had a little bit of a challenge in the fact that as a joint venture, we had, again, partners with Cleveland Clinic and Amwell with different views of success. And I'll say for the first 6 months that I was CEO of the clinic, the bulk of my time was really trying to get both parties on the same page in terms of what our success metrics were. Really talk about, what does a win look like from a patient standpoint, from a financial standpoint, for each organization who had different goals. It started with value creation, and it really is important to be able to answer 2 questions, like why you and why now is the right time. Because if there's no sense of urgency, if there's no sense of belief in terms of what your solution can deliver, it's going to be an uphill battle. So at the clinic, we had a virtual second opinion program, and we were helping patients with complex medical conditions around the globe access a Cleveland Clinic specialist rapidly and getting that second opinion for their condition. And these were people who were just told they had cancer, advanced cardiac disease, maybe they need a heart valve replacement, advanced or complex neurological condition. So as you can imagine, these, from a patient standpoint, were highly motivated. These people were scared, and they really wanted to get to the bottom of, is my diagnosis correct? And am I on the right path? So the problem we were solving was pretty clear. There's an estimated 700, almost 800,000 Americans will be permanently impacted or die from a medical misdiagnosis. So the impact is real. With rising healthcare costs, there's really a drive to how to avoid unnecessary surgeries. We found that about half of the spine surgeries that we did second opinions on, that really wasn't the best path forward for the patient, and a more conservative, also less costly approach, whether it was physical therapy and or other interventions, were really the best right next step. In terms of why the time right now, the the time was right now really was around all those key drivers. In terms of how does this impact the strategic imperative, there were a couple areas that we were able to move the needle. We found that 65% of people who came in for the second opinion had a change to their initial diagnosis or treatment plan. We found on average we could save $8,700 per second opinion based on getting that patient on the right intervention or the right treatment pathway. We were delivering a clinical product for Amwell, which, as a telehealth provider selling into health plans, that was a really important value driver for them. And for Cleveland Clinic, we were a powerful referral engine. And about 30% of the people who came into our second opinion program converted to care at Cleveland Clinic. That's because they developed a level of trust based on the insight and the direction they were getting from a Cleveland Clinic specialist. So when you talk about the institutional metric that mattered most, and if you think about the concept of a hedgehog from good to great, which is like, what is that one metric that matters most? We found that in terms of getting our board aligned and getting both of our partners aligned on the investment, patient conversion was that most powerful metric. And I really would emphasize that in terms of value creation is to be really thoughtful what number is moving the needle for the partner you're looking at. And depending on the partner, it may be a different number, but I think one of the benefits is really to make sure that you, as part of that partnership, understand what matters most to that potential partner. The next area of around building that partnership was around relationships, and trust is the operating system within an academic medical center. We found that the relationships that we had built took a lot of time. I mentioned with the board, I really spent an incredible amount of time building the relationship with the board. But it also, for me, was, since we dealt with all the specialties and all the institutes around Cleveland Clinic, was identifying across the enterprise who were the thought leaders, who were the things that were most important to driving our success. That was a bit of mapping the power centers, understanding the difference between the functional and clinical leadership. A lot about reliability is just showing up on time, but also, delivering what you say you will. Helps move you from partner and not just being a vendor. And critical is understanding, who makes decisions and who influences them. And oftentimes there's influencers that are behind the scenes that may not be evident up front. In my experience, there's a lot of people in an academic medical center like Cleveland Clinic who influence. There's a lot of people who will say, I've got a concern about this. Fewer people are ready to put their reputation on the line. So it really is important to make sure you're finding those people that have that influence. The chart on the right is a graphic actually I stole from another MCI webinar about selling into academic or selling into US health systems. But I thought it does a great job of kind of mapping out the influence spectrum, looking at what level of influence do folks have, as well as what level of support do they have for your project. And clearly, and it's pretty obvious that you want to put your energy in terms of really solidifying those relationships with people who have both high influence within the organization, they have got the organizational power, as well as are supporters and fans of what you're doing. And although you don't want to completely ignore the people who may be less influential, but could throw in some roadblocks. So it's a little bit of art and science. For us, we found there were three areas that had the significant impact for us in terms of relationships that made a difference. The first was the head of the Heart and Vascular Institute, and it really got into the point that Cleveland Clinic, at the end of the day, their root is as a cardiac care center, and they're doing some of the most advanced cardiac procedures in the world. It's high volume. It's also very important to the bottom line. So we really spent a lot of time building the relationship with the head of that institute, because that person was really important to success and continued involvement. There was a chief, the chief digital officer of the company was new to Cleveland Clinic and looking for innovative programs, and he was a real supporter and got what we were trying to achieve with the joint venture. There was also the chief of operations who was on our board and was very influential with the CEO of Cleveland Clinic. So, I spent personally time building those relationships, hearing their concerns, and making sure that we were taking advantage of the points of strength. Curious, from folks on the call, any relationship challenges or successes that folks want to share?
I
Yeah,
can share a bit. I think that this is really the most important point in the 5 points that you are speaking of. I don't think I can emphasize enough how important it is to build these relationships and invest in them. And you should start trying to build these relationships even before there's a tangible project, just to start finding the ways in. And if the door is closed, then find a window. If the windows are closed, find a chimney. Once you've assessed that this is the place that you want to work with. And the other thing is that it's absolutely impossible to build relationships without in-person meetings, in my experience. There's got to be these eyes locking. We've got to meet at some conference or something. There's got to be some kind of personal rapport to make anything move here, because it's far easier for these big hospitals to just forget about any startup from Israel. It's much more convenient. We're just,
Yeah, I
we're
think those
paying.
are two. Sorry, I was going to say, I think those are two excellent points. I think the best time to build a relationship is not when you're asking for something.
Mhm.
So you can't start too early trying to figure out who the right partners are and starting making relationships. And you may find that relationship or that institution is one that isn't strategically important in the future. It's still going to be a good investment to start that relationship. I think face-to-face meetings, we started the company in January of 2020, which on one hand was a great time to start a telehealth company. It was also a horrible time to be building relationships because everything was done over Zoom. And I can tell you, when travel started opening up, we found that relationships that were slow to warm up front, as we were able to spend time face to face with the physicians, the administrators, et cetera, it really helped us get additional traction. So thanks for sharing that, Rachel. Any other thoughts from the team?
think
Excellent.
there's another
Go ahead.
area which we're seeing more of lately, where the big academic centers, they're building their own ventures, and when they have a relationship at some point, they would like to be also partner in the innovation creation and do a co-development. I saw it with Cleveland Clinic, becoming almost a requirement to build the relationship.
Yeah, most of the AMCs do have a venture arm, and we did work closely with Cleveland Clinic Ventures. And they generally have two mandates. One is how to help accelerate commercialization of innovation coming from the walls of within Cleveland Clinic. So a cardiac surgeon designs a new valve. How do we try to make that a business? But also in terms of investments in interesting strategic technology. So that is an important route to look at. So appreciate you bringing that up. So in terms of relationships, I think everyone thinks about a physician champion when you're launching or when you're trying to launch an initiative with any hospital system is you need that physician champion. They bring credibility to their project. Uh, at Cleveland Clinic, if you're not a physician, your opinion may count, but it counts a heck of a lot more if you're particularly a surgeon. So that credibility of physician champion is really important that they can really break through the system. They become, I'll call it the expert witness, but particularly early on when maybe your clinical data is thin, they can really, from their expertise, help validate, no, this is sound science, that, I really believe in that. And, that means you need a, a physician champion that really is a little bit ready to go to bat for you. It's ideal if they're paired with operational ownership. We found that physicians who, were that this was where they had the P&L, where they had or operational responsibility, both they had more credibility, but particularly you're looking at a project and if they were the budget owner on that, it just is a heck of a lot easier to sell. Finally, you need a fighter. A physician champion who's lukewarm is going to get nothing done for you. So you need someone who's willing to take a bullet for you. There will be roadblocks. Large organizations, they want to make sure they're doing right by the patient, they're managing their reputation. So there will be many roadblocks along the way, and you need that physician champion who's going to be a tireless fighter for you. They exist, but it's really important to make sure that you're picking the right one. For a second opinion program, our chief medical officer played that role. He was a uh, neurovascular surgeon, well respected in the organization. He was the previous head of digital health, and he spent days, nights, weekends really just pushing forward when we had challenges, and whether it was recruiting physicians to participate in the program, we were trying to pre-sell funding of the program, dealing with regulatory issues, and found that having that person as that champion for us, that person who was waving our flag, made all the difference. I'll talk a little bit later about physician champion when it doesn't work. Finally, integration. And integration is where many pilots go to die. And it's just because things aren't scalable. One of the most important thrusts that we had with the Second Opinion program was how do we integrate what we were doing into the physician's day. The original program was they called them blue binders, and it was a paper-based program that was done for a million years, and it just wasn't scalable. The physicians hated it. It was slow. It took 41 days to turn around a second opinion. It was just awful. First thing we did was digitize that process, but we digitized it fully within the EHR to make sure it became easy for the physician. So a couple things on integration is, EHR is what I would call a gravity problem. You're not going to make gravity go away. You're not going to make the EHR go away. So you may need to fully integrate, or you need to make sure that whatever you're doing lives seamlessly alongside of it. From a physician standpoint, don't add clicks, minimize cognitive load. They're already working, 24/7. So make it easy for the physician. Understand that internal IT approval process, particularly with cybersecurity reviews, it can take a long time. So understanding that and building it into the program, as well as making sure that with the partner, there's a aligned view on what the metrics are for adoption, so that you can really keep track of stage gates Are we on track? Are we moving forward? So those are, the five things that I've learned that really make a difference in terms of a successful AMC partnership. I'm also going to give you an example of what not to do. And, we had a ton of success with our second opinion program. I can also tell you one program we tried to launch, which was a new digital program for congestive heart failure, fell flat on our face. And we learned a lot from it. So when you start and you look at from a problem definition, congestive heart failure affects 6.7 million Americans, expected to double by 2050. Annual cost to society, $31 billion. Half of US counties don't have a practicing cardiologist. Less than a quarter of patients are managed by the American Heart Association guideline directed therapy. So interesting, heart failure, the problem with isn't that we don't know what to do. The problem really is an execution. And we had demonstrated through an early pilot that a digital intervention could dramatically move the needle. We went from 25% on GDMT to close to 70% on GDMT. Patient scores, patient satisfaction, quality of life metrics were up. But despite all this good stuff going for us, the program didn't succeed. So why was that? Well, looking at the five pillars of alignment, value proposition, physician champion, integration, and relationship, we had a couple areas where you're strong, but we had a couple areas where we really missed the boat. And it started with alignment. And if you take only one thing away from the conversation today, it is how important alignment is to the success of a program. So Cleveland Clinic's Heart and Vascular Institute, which they go internal name is HVTI, limited resources, incredible pressure, really focused on complex procedures rather than medical management. If they had $1 to spend, it would be how do I increase capacity to do heart transplants, LVADs, valve replacement or valve repair, as opposed to how do I medically manage a heart failure patient. And that was a reality. Now we found there were other groups within Cleveland Clinic that did care about medical management, but that was more population health. So the alignment really doomed us from the start. Value proposition, big win for patients, but the payout from a surgical standpoint was longer than the organization was willing to put up with, given the fact that the staffing needs up front were significant. So part of our value proposition was by capturing a large population of heart failure patients, bringing them into the Cleveland Clinic umbrella. Not only are we going to help them in the short term, but long term, there will be procedures where you can help them. But that was a long-term payoff versus a short-term pain. Physician champion, we had a physician champion who was an expert on heart failure, smart. I mean, the guy was brilliant, really enthusiastic about the project, but wasn't positioned at the right level to get things going. Our integration, we had a decent integration plan technically, but from a patient workflow, since we were also bringing in outside physicians or outside of Cleveland Clinic into it, it became clunky, and that was one of the speed bumps we ran into. Finally, relationships. We had great relationships, but if the other pillars are not in line, the relationship isn't going to get you over that shortfall. So, at least in my learning, these things, when the five pillars are all aligned, it does provide a good ramp for success. But if you're missing, particularly on the alignment one, it's really hard to right the ship. So I've talked a lot about why to partner with academic medical centers. I'm also going to give now the opposing view is maybe you shouldn't partner with a rock star. Academic medical centers have a lot of people pursuing them. They are the rock stars of medicine, but they have a lot of fans. They have a lot of people chasing partnerships. So just like building a relationship with a rock star, it's going to be a lot of work. So I think a couple questions just to consider is, what's your board's comfort with this 18 to 24 month time investment it may take? You don't necessarily want to put all your eggs in one AMC's basket because you could come up empty-handed. Second question I'd raise is, could you get the credibility you need maybe from a thought, can you get the credibility you need from a thought leader at a second tier organization? So maybe a medical University of South Carolina versus a Mayo. Now it's an important decision because if you're trying to get medical credibility, that cardiologist, that neurologist has to have the reputation to publish the papers, et cetera. But you may find them at a different universe or different institution than the top 5 academic medical centers. Is your physician champion motivated and in a position to push things through roadblocks? If you don't have the right champion at an AMC, really take pause before you put a lot of investment. And then finally, what are the integration expenses and stage gates? The risk profile at an AMC is higher than it's the highest level of any medical institution. So it may be easier to implement at a smaller organization. But I think AMCs can be incredible partners. I'm not trying to say that you shouldn't partner with an AMC, but I think really go into it clarity in terms of what does success look like? What are my goals? As well as a realistic view of the effort. AMCs do shape the standard of care. So if you can get a Mayo, a Cleveland Clinic, Johns Hopkins, Stanford supporting your product, your brand, it has incredible weight. And when done right, partnerships can provide that durable advantage that really is important as you're trying to commercialize your product. So the question isn't whether or not an AMC is a good partner. The question is more, are they the right partner at this stage for your company around strategic fit, readiness, and timing? So that's what I wanted to cover today, and then wanted to spend a little bit of time for questions. And I'm just going to pause here and open it up for questions.
Yeah. This is Elena. I will be off camera. It's a little bit early for me in the US. I want to add some additional angles to that because I had a chance to partner with both, and I can totally relate to what you mentioned. I partnered with Cleveland Clinic on the therapeutic side. Take into account 2 additional considerations. One consideration, if you have a complex device or technology that will require FDA approval, find those centers where you have the physicians with good credibility with FDA. It can go far. That's the reason we partnered in the past with Cleveland Clinic for cardiovascular, and it was a huge success. It's an approved medication at the moment. In addition, if you decide to submit BIRD, bear in mind that on the US side for BIRD, the reviewers are coming from the NIH and the CEF world, and they may have good credibility with certain physicians that will go far through the review process of your grant submission for BIRD. And I can elaborate more on that if there are questions on that.
I think those are great points. And I think you were very clear in terms of what your goals were and the partnership. And getting through FDA, having the right supporters can make or break, can streamline a submission. So I think to me, again, it reinforces the point. Be really clear what you're trying to get out of the partnership. And is the partnership with the Cleveland Clinic critical? Or, is there another institution? It might be another AMC, or it could be another institution that gets you there. Any other questions, comments, thoughts? Mia, any questions coming through chat?
Not that I see any, but if anyone has a question, you can also unmute and ask.
Hey Frank, Conrad, thanks for sharing. An experience I had when I ran the MRI division of Philips, where we had very close contacts with the academics, and they were all